into regression discontinuity designs. So regression discontinuity, or RD, as you sometimes hear it called, or RDD, is a quasi-experimental design that elicits the causal effects of interventions by assigning an intervention or other exposure to those who fall above or below a cutoff or threshold value of a continuous variable. So this is a key feature of RD designs. Your exposure is based on a continuous variable, and this will become clear as we go through the example. So if you take that continuous variable, a continuous variable like age, or like cholesterol level, or blood pressure level, or CD4 count, these kinds of variables, if you compare the outcomes for people who lie closely on either side of the threshold, let's say it's a blood pressure threshold where treatment is given to people whose blood pressure is above, say, 140, but not to people who have blood pressure of 139. The fact is that those individuals who are slightly below or slightly above the threshold are not really that different with regard to most characteristics, except for that continuous variable. And this is in part due to the fact that it's a very small difference, but it's also in part due to the fact that the way we measure these continuous variables comes with some random error associated with it. So there's a little bit of random variation that happens naturally. So by comparing the outcomes for observations for people who lie closely on either side of this threshold, it's possible without randomization, but exploiting the random nature of the variable to estimate the average causal treatment effect of an exposure. So as an example here, there's something called, merit-based scholarships. So if students achieve a certain level of grades in their schoolwork, say 80% or higher, they get a scholarship that maybe gives them free tuition. Whereas students that have grades that are below that threshold are not given a scholarship. So this grade is a continuous variable, right? So you can ask the question, what is the effect of being given a scholarship on subsequent academic performance? And you can think about those people who are slightly below or above as essentially not that different from each other. There's a random component to grades, in addition to the non-random component that is driven by people's knowledge and people's talent, things like that. So other examples of exposure variables that you could think about to use in RD designs include things like age or income-based eligibility. Like, for example, if there's a legal drinking age threshold in the US, our legal drinking age is 21. So you can compare outcomes among people who are 21 compared to those who are 20, for example, to see if there's some kind of impact of the age threshold. Of drinking and blood pressure threshold, which I've already given an example, but there are many variables that fall into this category that could be exploited for regression discontinuity designs: cholesterol, hemoglobin A1C, CD4 counts, and we'll see an example of CD4 in a minute. But the idea is that if an intervention or exposure assignment is random at the threshold, so the 80% or the 140 for the hypertension treatment, then valid causal effects can be inferred. So in other words, in epidemiological language, individuals immediately above and below the threshold are similar in outcome expectations on all measured and unmeasured variables. So when do you use regression discontinuity designs? When the probability of exposure changes discontinuously at some threshold value of a continuously measured variable C. And there are two types of regression discontinuity that we can think about. One is called the sharp regression discontinuity, where the probability of a treatment or exposure changes abruptly from 0 to 1 at the threshold. And so this is, for example, when, regardless of any other factor, if your systolic blood pressure is 140 or higher, you will be given treatment. And so that in that situation where the exposure changes abruptly from 0 to 1 at the threshold, where treatment assignment is basically deterministic, you can estimate the average causal effect of the treatment. And then that's the other kind of regression discontinuity is fuzzy regression discontinuity. And that's when the probability of exposure changes at the threshold, but not necessarily from 0 to 1. And so there's a probability difference in whether or not that treatment exposure will change based on the threshold. And a good example here is treatment eligibility for HIV and how that worked prior to Treat All, where eligibility could be based on CD4, but not only CD4. There was also clinical status that came into play in determining whether or not someone was eligible. So that threshold value of CD4 count of 350, obviously if you're below the threshold, you're going to get treatment. But if you're above the threshold, it doesn't necessarily mean that you won't get treatment. It may depend on some other things like your clinical status. And in this situation, the fuzzy regression discontinuity design will tell you about the intent to treat effect. Regression discontinuity designs are generalizable to many kinds of outcomes. So not just continuous outcomes, but binary counts and time to event related outcomes like survival. And this is on the right here showing a schematic of the sharp regression discontinuity design, where here you have an observed outcome that's happening below the threshold, and what you see is discontinuity, a change in the probability of the outcome after above the threshold. We'll go through some examples on this. In thinking about applications, as I've kind of alluded to, these threshold rules really influence a wide range of potential exposures of interest, and they offer us really simple but rigorous approach to causal inference using observational data. So clinical diagnoses, the effect of being diagnosed with high blood pressure on sodium intake, clinical treatments such as the effect of cholesterol lowering medications on cardiovascular disease, or the effect of being a drinking age on the risk of suicide. Lots of potential applications, and as Annette implied, it's a matter of seeing opportunities and thinking creatively about how to utilize the data or exploit the data that might be available to you. So of course there are assumptions for regression discontinuity designs and also best practices. The first is that treatment assignment is essentially random at the threshold value. This can't be violated. In this case, I think I said random error in the measurement of the continuous variable is your friend. It really is what enables this design. One of the things that enables this design to work, and you can verify this by comparing the characteristics of people immediately on either side of the threshold. Another important assumption is that subjects cannot manipulate their treatment or exposure assignments. So, or clinicians can't change it. For example, by forcing people's values to change, or to force them to reassess if they're not above a threshold where they might get treatment, for example. This assumption can be verified with something called the density test. You would expect to see roughly the same number of observations appearing on either side of the threshold. If you don't see that, then it's evidence of something that clustering or bunching that suggests that there may be some manipulation happening. Also, there should be no other co-occurring discontinuities. So in our country, Medicare, which is insurance for older people, begins at age 65. So you could think about a study that's looking at, an age cutoff of 65 to see if Medicare has an influence on survival in the following year of eligibility. But then you also have to realize that there may be other things that happen at age 65, such as we have a Social Security system in the US that kicks in at age 65 for many individuals. So this would be a potential problem for causal inference in regression discontinuity. You also would expect, because of the random exchangeability that can happen around the threshold, that if you were to adjust for covariates, and you can when you have this information, that it should not really change your findings very much, right? Because if it did, that might mean that the above assumptions are not valid. But if in fact there's truly random assignment on either side of the threshold, adjusting for covariates shouldn't change your findings very much. And also, similar to difference in difference, treatment or exposure variables shouldn't be associated with prior values of the outcome. If this happens, it also suggests that the assignment wasn't random at the threshold value. Regression discontinuity, this is a feature of software programs that allow you to have the data determine what the bandwidth is. In other words, what the window around the threshold would be to include in your analysis. This can be determined by the software, and a best practice is to actually have the software do that as opposed to the investigator. And so sensitivity analyses can be used for other bandwidths, but the bandwidth choice should be data-driven for your main results. And there's a publication that goes into more detail about that. So the example I chose to share with you guys for regression discontinuity design, the article that I gave to Annette and folks there organizing the workshop by Jacob Bohr is really an excellent article. It goes into the methodological details, and it also presents this really nice worked example. They were interested in an application that was getting at a really pressing question, which is when, this was prior to treat all, when in the course of HIV disease progression should ART be started? It's not a question where there have been many RCTs, and really maybe only a handful have looked at this question, and none of them had looked at it in sub-Saharan Africa. And it's not the kind of RCT that you wouldn't expect there to be many more RCTs on this issue. There were guidelines that were evidence informed, and that was really driving policy. But what they thought, given that there were not going to be RCTs, they decided to exploit a continuous variable of CD4 count, first CD4 count for patients, to assess the causal effect of early versus delayed ART eligibility on survival. So would earlier treatment improve survival in a cohort of patients infected with HIV in South Africa? And so this is one of the first descriptive analyses they did, was to just look at the distribution of the first CD4 count. And at the time, the 200 threshold was in effect in South Africa. And here's where you see, again, if there was manipulation of the of this variable by clinicians or by patients, you would expect to see, you might expect to see a much higher distribution of patients with CD4 just below 200 than those just above. And in fact, what they showed here is there's really not that big of a difference. No evidence of bunching CD4 counts at the threshold of 200. So that was looking at one of the first key assumptions for regression discontinuity. They also compared the characteristics of patients who who fell immediately above and below this threshold, and showed that the covariates were balanced, similar to an RCT. And so on the left side here, let me just try to orient you to the slide here. The proportion, the cumulative probability of initiating treatment for patients who were below CD4 count of 200 within 3 months in the blue dots, and within 12 months of that CD4 count. And so you can see that at the threshold, there is a very big drop, discontinuity, in the likelihood of ART initiation, whether or not you were below, immediately below, or immediately above the 200 threshold. And this is shown over here. The hazards of death associated with being above or below that threshold were really quite different. So if you were immediately above the threshold of 200, you were more likely less likely to survive, thereby demonstrating, in fact, with a hazard ratio of 0.65, the higher risk of waiting till your CD4 drops below 200 on mortality. And this could be interpreted as a causal effect, and very strong evidence that the 200 threshold is not good for patients as it relates to risk of mortality. So that's an example of regression discontinuity, and we'll see some more tomorrow as well.
Thank you, Dennis.
Any questions on that?
Can we go to the previous slide so they can just see that while we're okay? So Steph Barral talked about regression discontinuity like at least, I don't know, 3-4 times. He threw it out there because he considers it to be really interesting use of this tool within data like HIV cohort data like IDEA. But now that you explain it to us, I'm a little nervous about people being able to do this unless they have a biostatistician that really knows how to use this model, because it sounds really attractive, but I don't think anybody here has actually implemented one. It might still be a bit new for many people around here. Do you have any tips or insights into sort of either say, yes, you really need someone who knows how to do this, or this is actually a tool that can be learned without too much difficulty? And just FYI, you have the Bohr paper in your Dropbox for your pre-reading for this workshop. Dennis?
So I think one of the things, if you read the Bohr paper, it kind of starts out with, the reason they wrote the paper is because they feel like it's an underutilized design in epidemiology, and with great potential for more fruitful application. And so I think that and what has happened is that in not just biostatistics training, but also epidemiology training, it's becoming more common for students to learn, especially PhD in epi students, to learn this method. So it doesn't have to be a biostatistician per se, but someone recently trained in epidemiology will likely have the ability to do this. But there's also, you could also take, short courses in learning how to apply the methods. And our doctoral students here at CUNY in epidemiology have had success in learning the ins and outs of the method and how to test the assumptions and things like that.